Perioperative care. This is the surgery department. This is pre-op, this is intra-op, which is actually in the OR suite itself, and this is PACU or recovery. Right, their objectives. Surgery. There's multiple different types of surgery. This is not relevant for answering NCLEX questions, but they are in two different categories. This is really not going to be an aspect for you in the real world. We're not going to put patients into categories of surgeries. So nursing assessment. All right, so some aspects with nursing assessment in the perioperative suites, okay? Perioperative. Perioperative is before the surgery, before the surgery. First thing is determining the patient's mental capacity. Are they alert 90 times 4? If they're not, is there a power of attorney located with the patient in the OR, in periop? Pregnancy test. These are typically done just with dipsticks. In the pre-op area, the majority of time, if somebody is pregnant, we are not going to be doing the surgery. Yes, there are cases that we are going to be doing the surgery even if they're pregnant, and there's cases where we're doing surgery on the baby inside the mom. So there's a lot of different aspects, but the majority of surgeries will not be done if the patient is pregnant, okay? Radiology and lab results. Now, it's a lot easier to have these results in the chart because now everything's digital. But if there's anything extremely off, we do need to let the surgeon know. It doesn't mean the surgery is going to be canceled, but there are things that we might be giving the patient right before surgery or right after surgery. So let's say the patient's hemoglobin and hematocrit, they're H&H, they're anemic, they're low. We might do a type and cross to have some blood ready in surgery in case we need it. We just want to plan. It doesn't mean the surgery is going to be canceled. We are also going to teach the patient deep breathing and coughing. Even if the patient did not have surgery on the chest or abdomen, anesthesia and pain medications suppress the lung respiratory drive. So we're going to teach them how to do that deep breathing and coughing. We're going to teach them the incentive spirometer. And we teach them before because it's hard to teach somebody after they've had general anesthesia. Their memory capacity will be diminished for a couple days. That's normal, okay? Then there is something that we teach patients called splinting. Splinting is actually for pain control. So let's say you had a surgery on your abdomen, okay? We want the patient deep breathing and coughing after surgery, especially with chest and abdominal surgery. We get the patient a little pillow. They push the pillow against their incision and they cough and deep breathe. The splinting is reinforcement. It's for pain control. We're not just going to keep throwing pain medications at a patient. That can just make things worse, okay? We're not going to withhold pain medication, but there's multiple things we can do to help with pain issues. This is going to seem very fundamentals, but the most common, highest priority for infection control is washing of said hands. So we're going to teach the patient before they do any incisional care at home, wash your hands. Oh, I did that. All right, legal prep. It is the surgeon's job. The surgeon. It is the surgeon's job to talk to the patient about the surgery. As an RN, I don't care if you know the surgery. I don't care if you could do the surgery. I worked in surgery for 8 years. There are surgeries I could do without the physician there by the time I left surgery. I am not the surgeon. I do not have an MD behind my name. I am not responsible for the surgery. The surgeon is. If the patient has a question about the surgery, get the surgeon. If you think the patient is planning any type of too demanding physical activity after the surgery, get the surgeon. I had a patient once coming in for a surgery and he was signed up for a marathon the weekend after. Absolutely not. I don't care how minor the surgery is. That's not going to happen. The surgeon's not going to go for it at all. It is absolutely up to the surgeon, though, when it comes to any type of surgery consent. As an RN, we cannot explain anything to the patient about the surgery. It is the surgeon's job to explain the surgery. It's a surgeon's job to get the consent. That's why very often the surgeon will actually get the consent while the patient was still in the doctor's office, weeks or even a month or two before the planned surgery. Everything then is done. It's in the chart. We don't have. So priority before the surgery. Now, there's a lot on this list. We're not going to hit them all, okay? So we're just going to talk about the real important ones. NPO status, or MPO status. Most surgeries, the patient needs to be MPO, other than maybe a sip or two with water with medications, at least 8 hours before the surgery. I have had surgeries cancel where patients admitted that they were coming into the hospital and stopped somewhere and grabbed a breakfast biscuit. We're not doing surgery. It is too risky. I have had patients on the table aspirate because they lied and said they did not eat and they almost died. It is a very big deal. We talked about teaching, we talked about the consent. Allergies. Allergies are going to be important. Again, it's not that we're not going to do surgeries, we just want to be prepped for it. So any type of medication allergies, we want to know. Any type of food allergies. If you did not know, a very common food allergy where the patient's actually allergic to latex is if the patient has an allergy to avocados or bananas. We want to know. If they break out in hives or they have some guacamole, I want to know because that means I can't have any latex in my OR room, and that is fine. We just want to be prepared. That's all. We just want to be prepared. IVP dye, shellfish, okay? If a patient has a history of eating shellfish, and again, they had an anaphylactic shock, they had hives, they had rashes, we just need to know. There are things we can do. We just want to be prepared. Jewelry, we prefer the patient not to have it on, but it's typically not going to be a big deal if they don't, okay? Again, we talked about the lab work, that if there's anything abnormal, we've let the surgeon know, and we have the solutions for that ready to go. Intraoperative care. This is when the patient actually goes into the OR suite, okay? There are 3 different zones to surgery itself. The first one we just talked about, this is the unrestricted area. This is pre-op. This is where the patient, you could walk into this area in street clothes. You could have your Skechers on, blue jeans on, and a hoodie, and this would be absolutely fine, okay? No problems with this whatsoever. This is where the family members can come. This is where we can kind of roam around as we see fit. Then we go to the semi-restricted area. The semi-restricted area is the hallways and rooms right outside of the OR suites themselves. Like you see in the picture, very typically, there's multiple windows you can see inside the OR suites, but these are the areas and the hallways around. This is for OR personnel only. We don't want a whole bunch of people back here. It's a huge infection risk. We have to have our OR blues on with this. We have to have our hair pulled back and in our caps, and the appropriate shoe wearing. Then the final one is the actual OR suite itself. So this is a traditional operating room. It is not that flashy. If you've seen Grey's Anatomy, it is not that big. Those Grey's Anatomy OR suites are massive, okay? This is very typical. You can see the anesthesia machine in the back corner. You can see the lights, and you can see the OR suite. This is for only immediate individuals that need to be in the OR suite for the surgery. If you do not need to be there, we are probably going to ask you to leave. We do observations in the OR. We have nursing students come in all the time, but if there's a lot of things going on, there's a lot of people, we will start asking people to leave if they are not needed for the procedure. The team itself, this is really not something. We talked about the latex allergy. If they have a avocado or banana allergy, we will make sure there's no latex in the patient's room. We're just going to err on the side of caution. Different classifications of anesthesia. Now you probably know these, but you don't even know you knew these, okay? So general anesthesia. This is the full gambit. The patient's intubated. They're put into a medical induced coma, and they're typically giving something called a paralytic that prevents the muscles from responding. Okay? Then you have a local anesthetic. They do them at the dentist's office. They do it if they have a mole removal or an abnormal skin area at the dermatology office. You just get lidocained up. The patient's completely breathing, walking, talking. It's just the very specific area that gets numb so they can do the surgery there. And then you have renal anesthesia. This is where we do blocks. Most common renal anesthesia is an epidural for childbirth. That is where we go into the spine, we numb everything below the area of the spine, and the patient can't feel it. We actually can do this with hip surgeries, knee surgeries, shoulder surgeries. There's all different types of regional anesthesia that we can do. Complications. Now, while these complications are not common, they're still complications. So cardiac arrest, massive blood loss, anaphylactic reaction, and malignant hyperthermia, okay? You can have an anaphylactic reaction pretty much from anything. So it doesn't have to be necessarily medication induced. People have anaphylactic reaction again for shellfish, latex allergies, different foods. So we just want to be very cognizant if they have an allergy, what the allergy is to. Now, malignant hyperthermia. A lot of individuals may have never heard of this. Completely understandable. It is not well known, but it is incredibly deadly. An individual that has a condition called malignant hyperthermia, first of all, sometimes they don't even know they have it. It is 100% a family trait. For a patient to have malignant hyperthermia, either their mother or their father had the gene, had the trait, and it was given to them at conception, okay? There isn't a whole lot of tests that can be done to absolutely definitively say if the patient has malignant hyperthermia. But what happens is we bring the patient back to surgery and there are medication triggers. On the slide here, we're on slide 23. The most common triggered are the anesthesia agents that we use the most commonly. Succinylcholine and ethylene are the two major triggers of malignant hyperthermia. So if you say, well, just don't use those, that's not a bad idea, except the fact that there's such a minor percentage of the population that has malignant hyperthermia, and those two medications work really well when we're doing general anesthesia. But what we see is when we give one of these and we trigger the malignant hyperthermia, we have minutes. I'm not exaggerating, before the patient's dead. I've had 2 patients in my career that have had malignant hyperthermia reaction. One where the patient was in the ICU. He was a vet. He had been exposed to Agent Orange when he was in the military. He came into my hospital. He was in the ICU, and the physician, this is completely a normal practice, nothing abnormal. We're going to put him into a medical induced coma because he's having some difficulty issues. We're going to let his body rest for a couple days, and then we'll take him out of the coma in a couple days. Very routine. The intensivist asked me to get the doses of succinylcholine. The patient consented. This was not abnormal. We had done it with this patient before. And what happened is after I gave him the succinylcholine, his body got rigid, like a 2x4. We could barely move his jaw. This man died 3 minutes after I gave the first dose of succinylcholine. Didn't even see it coming, okay? Fast forward many, many years. I'm working in the OR. I have a younger patient come in. He's having a shoulder surgery. My physician, my anesthesiologist, gives him the dose of succinylcholine. Now, mind you, this younger patient in the OR, we did all the checks. Nobody in the family had heard of malignant hyperthermia, but nobody had a surgery history either. Now, this story ends with a patient living through it, but very similar. my anesthesiologist, Dr. Ringwald, gave him the dose of succinylcholine. He went rigid and his body temperature skyrocketed to 106 Fahrenheit. Okay. We called a code. Pause right there. This is what we do. This is the treatment for malignant hyperthermia. So if you're on the guided notes, which you should be on the guided notes, on the second page, it says, list the steps of treatment in order for malignant hyperthermia. The first thing we do is stop the surgery and stop the anesthesia causing the issue, okay? So you take away the thing that hurts the patient. The second thing is we're going to go to 100% oxygen. Now, if the patient's already intubated, this is going to be really easy, okay? Then the third step is cooling the patient off. So we get cooling blankets, lavage kits, ice saline, okay? We got to cool them off. Remember, my patient was 106 within seconds. Pulling labs for electrolyte imbalance, there will be an electrolyte imbalance. There will be several. So we want to get that blood going. We want to get the labs going. And then the last thing is actually the treatment. The actual treatment of malignant hyperthermia is something called dantrolene. Right now, dantrolene is the only widely used medication, but dantrolene comes in a crystallized powdered form. So we have to reconstitute dantrolene with sterile water. That takes a minute or two. So that's why the dantrolene medication is the last step, because we can do everything else first while we could have a dozen or so people mixing the doses of dantrolene. So this is the this is the treatments to the orders and the treatments to fix malignant hyperthermia. My second patient here, he did live, and he did come back a couple months to actually do the surgery. All right, now we're on the final step of surgery, which is PACU. The patient has finished his surgery. It was a success, and now we are over in recovery. The most important for the PACU nurse is going to be airway breathing, airway breathing, airway breathing all day long. We want to make sure they're breathing on their own. We want to make sure that their airway is clear, and we want to make sure their pulse ox is within normal limits here, okay? The second thing we're going to be looking for is bleeding at the incision site. If you have patient that is bleeding from their incision site, and it can happen sometimes, most of the time it's very minor, do not leave that patient. Do not leave that patient. I want you to write down, do not leave that patient. You need to put pressure on the incision site. Just think about it. If you're at home and you're cutting vegetables for dinner or cutting fruit for a smoothie and you cut yourself, what do? You hold pressure, okay? Don't leave your patient, hold pressure, and then just yell for some help. Don't call anybody, don't call the surgeon, don't call the anesthesiologist. Hold pressure and see if that works first. All right, you guys, that is it when it comes to perioperative care. I hope you learned something. Thank you much.